Dr. Amirtha Thampi is associated with Pallium India as the head of Clinical Services Department. She is a compassionate individual committed to patient welfare with around a decade of experience in palliative care. She is passionate about the covered potential of palliative care in enhancing quality of life for the patients as well as the families. She is trained in promoting assessment and improvement of cancer experience via the Stanford Medical and PCPACE India collaborative program. She have also have a global fellowship in palliative medicine. She has co-authored multiple research journals in palliative care, including antibiotic stewardship in Indian palliative care. Welcome, ma'am, for the session and OT.
Thank you, Senior, for that kind introduction. Good afternoon, all. So, as Senior has already mentioned, today we'll be dealing with the Step 1 analgesic ladder, WHO analgesic ladder. Can you see my screen? I hope my screen is visible.
Yes, ma'am.
Thank you. Thank you for that. And so we'll be starting with the step 1 and 2 medications of the WHO analgesic ladder for cancer pain management. So I hope all of you are already familiar with the WHO analgesic ladder for cancer pain management, but I'll just brush through it. As you are aware, the step 1 of the WHO analgesic ladder for cancer pain management includes non-opioid drugs plus or minus adjuvant for mild pain. And if the pain is persisting or increasing, then we escalate to step 2, which comprises of opioids for mild to moderate pain, plus or minus step 1, which is non-opioids plus or minus adjuvants. And if the pain is further increasing, we escalate to step 3, which is opioids for moderate to severe pain, plus or minus non-opioids, plus or minus adjuvants. So next, we'll be dealing with the patient scenario. So we have a 55-year-old lady, Mrs. X, who has a swelling on the right foot, which is tender, warm, and she finds it difficult to move that limb. She gives a history of an injury to the foot 3 days back. Her pain is a continuous throbbing kind of pain with a score of 5 by 10. How will you manage her pain? I would request you to either unmute and speak, or you can type in your chat box. How can we manage this lady's pain? She has a continuous throbbing kind of pain with a score of 5 by 10.
Hello, we can give a mild analgesic to her, and also if swelling is there, we can give a maxil compression for the swelling leg.
Thank you, Sister Lily, for that response. Anybody else want to add anything more to that? Okay, so we are proceeding with, so as the pain score or the intensity of the pain is already mentioned, it is 5 by 10, which shows that it is a mild pain. And we, according to the WHO analgesic ladder that we just now saw, it states that we'll move with step 1 analgesic drugs, which includes non-opioids plus or minus adjuvant drugs. So what are step 1 drugs? So these are drugs which are used in mild to moderate pain. And these step 1 drugs include paracetamol, non-steroid anti-inflammatory drugs, and it can be combined with an adjuvant drug. So we'll first discuss about the non-steroid anti-inflammatory medications or NSAIDs. So I hope all of you are know about the pain pathway. As you all know, when a tissue injury occurs, what happens is that some chemical mediators like bradykinin, prostaglandins, histamines are released. And these chemical mediators, what do? They sensitize the nerve endings and they amplify the pain signals. So this is regarding the role of the prostaglandins. So, and they amplifies the pain signals and results in the transmission of pain signals from the periphery. It travels through the to the dorsal root ganglion to the dorsal horn of the spinal cord, and through the lateral spinothalamic tract, it reaches the hypothalamus, and from the hypothalamus, the pain impulses reaches the somatosensory area of the cerebral cortex. And it is there in the somatosensory area of the cerebral cortex that the pain is perceived. So this is how the pain perception happens, and I'm sure you have already dealt with the pathophysiology of the pain. So what does NSAIDs do? So NSAIDs are the first step in the WHO analgesic ladder for cancer pain management for mild to moderate pain, usually associated with inflammation. And as I mentioned, the chemical mediators being released during a tissue injury includes prostaglandins, then we have bradykinins, histamines, several other chemical mediators are also being released, and these sensitize the nerve endings and they amplifies the pain signal and facilitate the transmission of the pain signals. So what does the NSAIDs do? So the tissue membrane, the membrane phospholipids, they release arachidonic acid. And this arachidonic acid is being converted to prostaglandins or prosthenoids. Prosthenoids include prostaglandins, thromboxane A2, and prostacyclins. And this conversion of arachidonic acid to prostaglandins is with the help of cyclooxygenase enzyme. And what NSAIDs do is that they inhibit the cyclooxygenase enzyme. So that is the prostaglandins, they sensitize the nerve fibers and result in the transmission of the pain impulses. So this prostaglandin synthesis is being inhibited by the NSAIDs. How? The enzyme which is needed for the conversion of arachidonic acid to prosthenoids is being inhibited by the NSAIDs. That is, a cyclooxygenase enzyme is being inhibited. The cyclooxygenase enzyme usually exists in two forms, that is COX-1 and COX-2. So COX-1, it is a normal constitutive or housekeeping enzyme which is present in all the normal tissues, especially in the gastrointestinal tract, platelets, kidneys, etc. And they mediate the physiological response. These are gastroprotective. They protect the stomach, kidney, and also facilitate platelet aggregation. So this enzyme is a desirable enzyme, and the inhibition of this enzyme or COX-1 inhibition is not a desirable for our body. Just keep this in mind. Now we'll be talking about the COX-2. So COX-2 enzyme, it is an inducible one that occurs only during the inflammation. And it is mainly present in the lungs, brains, kidneys, testes, etc. And it mediates the prostacyclin synthesis. So it is an inhibitor of platelet aggregation and it causes vasodilatation. Now, what is your favorite NSAID? Can somebody tell me your favorite NSAID? You can either unmute and speak or you can put it in your chat box.
Tablet Ultraset, tablet Calcos.
So, we'll be coming to that. Ultraset.
Tablet composition.
Naproxen. Okay. So, paracetamol is not a non-steroidal anti-inflammatory drug. So we'll be talking about paracetamol after the NSAIDs. Yes, ibuprofen is a non-steroidal anti-inflammatory drug. Yes, diclofenac. Thank you. So, and these NSAIDs are being classified depending upon their inhibition of cyclooxygenase enzyme. And if the NSAIDs can act on COX-1 or COX-2, and depending upon this, they are classified as non-selective COX inhibitors. So when we say non-selective COX inhibitors, it means that they can block cyclooxygenase 1 and cyclooxygenase 2 enzymes. So they can block COX-1 and COX-2. And the drugs which are non-selective COX inhibitors include ibuprofen, mefenamic acid, ketorolac, piroxicam, etc. And how do these non-selective NSAIDs act? So we have already said that they inhibit both COX-1 as well as COX-2. So as I already mentioned, the inhibition of COX-1 is not a desirable effect. So when there is inhibition of COX-1 derived prostanoids, it results in gastrointestinal side effects like bleeding, hypersensitivities like angioedema, urticaria, bronchospasm, and adverse renal effects also. Whereas inhibition of COX-2 derived prostanoids, it is the beneficial effect and it is responsible for the anti-inflammatory, analgesic, and antipyretic effects of NSAID. So COX-1 inhibition is not a desirable action, but whereas COX-2 inhibition is beneficial and it produces the anti-inflammatory, analgesic, and antipyretic effect of NSAIDs. So when we say non-selective NSAIDs, they can inhibit both COX-1 and COX-2. So what are the side effects of non-selective NSAIDs? We already mentioned that the non-selective NSAIDs are inhibiting the COX-1 also. That is a gastroprotective is also being inhibited. So it has got renal side effects. It can cause sodium and water retention. It can cause acute renal failure in patients with kidney disease. So gastrointestinal side effects include bleeding, ulceration, and it can also produce hypersensitivity reactions in the respiratory system, in the skin, generalized. These are all the side effects of non-selective NSAIDs. So that was non-selective. Now we have preferential COX-2 inhibitors. When we say preferential COX-2 inhibitors, they block COX-2 relatively more than COX-1. And these include diclofenac, meloxicam, nimesulide. And we have the selective COX-2 inhibitors. The selective COX-2 inhibitors are drugs or NSAIDs that block the COX-2 enzyme. So these includes the COXIBs like silicosib, rofecoxib, valdecoxib, etoricoxib, etc. And diclofenac is now considered as a selective COX-2 inhibitor. So ibuprofen is has the lowest risk among the traditional NSAIDs. And the intermediate risk is diclofenac and naproxen, and the greatest risk is with piroxicam and ketorolac. And these are the risk factors associated with NSAIDs toxicity. So we have GI side effects, we have renal side effects, as well as we have cardiac effects. So the risk factors for GI toxicity or gastrointestinal toxicity is advanced age. Patients with advanced age, high and prolonged use of NSAIDs can result in GI toxicities. History of upper GI symptoms or bleed, and concurrent use of aspirin, steroids, and anticoagulants can also result in GI toxicities. And for renal toxicities, patients with dehydration, concurrent use of nephrotoxic drugs or beta blockers, advanced age, poorly controlled diabetes, ACE inhibitors, creatinine clearance less than 30 ml per minute. All these conditions are risk factors for renal toxicity. And advanced age, diabetes, hypertension, hyperlipidemia, smoking, all these are risk factors for stroke and myocardial infarction. And also use of COX-2 drugs can also result in its prothrombotic, and hence it can result in stroke or myocardial infarction. So Are selective COX-2 inhibitors safe as compared to non-selective COX inhibitors? So when we say selective COX-2 inhibitors, they inhibit only the COX-2 enzyme. So what are the advantages? They are safer on the gastrointestinal tract as compared to non-selective. So non-selective, it inhibits both COX-1 and COX-2. So they are safer. Selective COX-2 inhibitors are safer on gastrointestinal tract. Whereas the renal damage is almost comparable with the non-selective NSAIDs. And prothrombotic effect is more in selective COX-2 inhibitors. They are more likely to cause myocardial infarction and stroke. And in fact, selective COX-2 inhibitors like rofecoxib have been taken off from the market in 2004 because of this adverse effects. So what are the precautions that we should take while using NSAIDs? Administer with a gastroprotective drug like proton pump inhibitor. So always when you prescribe an NSAID, make sure that the prescription has a proton pump inhibitor like pantoprazole. Cautious use in patients with acid peptic disease, advanced age, smokers, alcoholics, patients on steroid treatment, coronary artery disease, hypertensive patients, asthmatic, patients with renal dysfunction and gout. And ensure that there is adequate water intake. Always avoid NSAIDs in dehydration. And avoid if there is a bleeding tendency or with anticoagulants. COX-2 selective inhibitors are contraindicated in atherosclerotic disease, coronary artery disease, and cerebrovascular disease. So this is regarding the recommendation for the use of NSAIDs by the American Heart Association by a study on patients with ischemic heart disease. And according to them, they suggest that the least risky medication should be tried first and escalate the medication only if the medication is ineffective, you escalate it to the next step. And always start with the acetaminophen or aspirin at the lowest efficacious dose, and especially for short term. And if you are moving on to NSAIDs, always start with non-selective NSAIDs. And there are certain conditions, that is, select the patients at low risk of thrombotic events and prescribe the lowest dose required to control symptoms. And add acetyl salicylic acid and PPIs to patients at increased risk of thrombotic events. Start with non-selective NSAIDs, then preferential COX-2 NSAIDs, and then only to selective COX-2 NSAIDs in patients with ischemic heart disease. And though there is a potential for abuse, narcotic medications can be given for short-term pain relief. This is what the American Heart Association recommends. Now, we are moving on to the other step 1 drug, which is paracetamol. So paracetamol, it inhibits the cyclooxygenase enzyme in the central nervous system. So it has a predominant central action and has no effect on the peripheral COX. Hence, it has less side effects. So it can be used as an antipyretic and analgesic action, but has no anti-inflammatory action. And paracetamol can be used as an NSAID sparer in patients with chronic pain, and the benefits are reduced adverse effects and cost effectiveness with paracetamol than NSAIDs. And the therapeutic dose of acetaminophen or paracetamol is 3 to 6 grams per day, and overuse of acetaminophen may result in serious hepatotoxicity. And it can be safely given in chronic liver disease at a dose of 2 to 3 grams per day. Moving on, we have another patient scenario. Mr. S, a 35-year-old man, father of 2 young kids, has been diagnosed with carcinoma of upper lobe of right lung and has deep-seated gnawing pain over the right suprascapular and infraclavicular area with a pain score of 3/10, continuous in nature. He is unable to sleep at night. How will you manage the pain? So he is currently on. So he is currently on paracetamol 750 milligram 4 times a day with ibuprofen 400 milligram 3 times a day and pantoprazole 40 milligram once daily. But he has incomplete pain relief. How will you proceed? Please unmute and speak, or you can type in your chat box. How can we proceed with the pain relief for this patient? Anybody has any suggestions? So we have already started him with paracetamol and ibuprofen and found that the pain relief is incomplete. How do we proceed? You are all familiar by now with the WHO analgesic ladder for cancer pain management.
Can give Tramadol.
Yes. Thank you. Thank you for that response. Thank you for that. So the patient is already on the optimal dose of step 1 medications. So according to our WHO analgesic ladder for cancer pain management, the next option would be the step 2 drugs. And that is opioids for mild to moderate pain. What are the opioids for mild to moderate pain? Yes, of course, tramadol. And then anyone else has any other suggestions? Yes, so we have tramadol.
Tramadol plus Perinom.
Tramadol plus perinom. Why you want to add perinom? Vishnu, why you want to add?
Vomiting sensation.
Very good. Yes. Okay, so tramadol plus an antiemetic can be given. Any other drugs? We have tapentadol.
Or Amiset.
Yes. Amiset is another antiemetic that can be added. So opioids for mild to moderate pain include tramadol, tapentadol, codeine, dextropropoxyphene. So we'll be dealing with the tramadol and tapentadol today. So tramadol, regarding the mechanism of action of tramadol, as you know, it is a opioid receptor. So it has an action on the opioid receptors. It is a mu agonist drug which acts on the opioid receptors, and also it inhibits the reuptake of serotonin and noradrenaline. So that is basically how tramadol acts. So it has two actions. It has an action on the opioid receptors as well as it inhibits the serotonin or adrenaline reuptake. Do you know any other group of medications that have the same action? Inhibition of serotonin and noradrenaline reuptake. Anybody?
Some sedatives.
Sedatives. So actually the tricyclic antidepressants also act by serotonin noradrenaline reuptake inhibition. So we'll be dealing with that. So regarding tramadol, the potency of tramadol is 1/10 of morphine and it lowers the seizure threshold. And as Vishnu was mentioning, one of the dose limiting side effects of tramadol is nausea. Tramadol can produce nausea, and it is always preferred to prescribe an antiemetic along with tramadol. And preferably metoclopramide, which is a prokinetic drug. Antiemetic is usually preferred with tramadol. And the duration of action of tramadol is 4 to 9 hours, and the maximum dose is 400 milligram per day. And this is a comparison between tramadol and tapentadol. Tapentadol also is a mu agonist, and it acts on the mu opioid receptors. It inhibits the reuptake of noradrenaline more than serotonin. It inhibits the reuptake of noradrenaline, and it does not have any active metabolites. And regarding the potency, it is 1/3 that of morphine, whereas tramadol is 1/10 of morphine. And tapentadol has lesser drug interactions compared to tramadol, and the maximum dose of tapentadol is 600 milligram per day. So we have another patient story. A 70-year-old man, Mr. P, who has carcinoma of lung and is complaining of throbbing pain on the right front of chest, which is continuous with a score of 5/10. He is a non-epileptic and is on levetiracetam 500 milligram twice daily. How will you manage his pain? You can either type on the chat box or you can unmute and speak. How can we manage this patient's pain? There's a
Tramadol plus
particular-
Perinom.
By paracetamol and
Paracetamol 1 gram, Tramadol plus Perinom. Tramadol 50 mg and Perinom 10 mg.
So why do you want to use tramadol? Can anyone answer me why you want to use tramadol?
Hello?
Yes, Vishnu.
Oh, okay, madam.
Why do you want to use tramadol? Anyone can answer.
His pain scale score is 5. 5.
Yeah, so the patient has
The management is paracetamol. Actually, injection is not good for compared to tablet is good. Tramadol tablet is most effective.
Okay.
According to in our hospital, Kollam Medical College, Dr. Yadav sir, I prescribe all patients for tramadol tablet.
Yes. So, Vishnu, what
Compared to
you said?
injection, compared to tramadol injection, tablet is more effective.
Okay. So, but there is a catch in this, Vishnu. So, as you said, the patient is having a pain score of 5/10, and it is more like a nociceptive pain, and patient. So, we understood that the patient's pain is in a moderate level. So, step 2 would be beneficial. So, it could be opioids for mild to moderate pain, which includes tramadol, tapentadol, codeine, dextropropoxyphene, etc. But
Okay.
we have also just now learned that tramadol reduces the seizure threshold. Tramadol lowers the seizure threshold, and this patient is on an anti-epileptic, and he is prone to have epilepsy. So it is always recommendable in this patient to use a low dose of step 3 opioid than proceeding with step 2 opioids like tramadol. I hope it's clear. Tramadol is a drug which reduces the seizure threshold, and so patients already prone to have seizures or already on anti-epileptics, we don't prescribe tramadol. So it is always advisable to give a low dose of step 3 opioid. So we can prescribe morphine on a low dose for such patients. Okay. So next, we are moving on to codeine. Codeine is 1/10 as potent as morphine, and it is a prodrug of morphine, and the main metabolite is codeine 6-glucuronide, and the onset of action is 30 to 60 minutes, and the duration is from 4 to 6 hours. And the uses of codeine is mainly for pain relief. It can be used as a cough suppressant and as an anti-diarrheal. But mostly the codeine preparation is not available with in India. It is mostly available in the form of cough syrups and all. So usually this
So
is
it's in government sector, codeine is not available.
yeah, codeine is not readily available.
It is, but in government sector, tramadol is mostly available. Codeine is narcotic drug. They kept it in narcotic box. Hello.
Yes. So tramadol as well as codeine, they are step 2 opioids. They are opioids for mild to moderate pain. But codeine is not readily available in India, and hence codeine is not much prescribed other than as a cough suppressant in some this suppressant preparations like cough syrup preparations. It is not readily available, so it is not much prescribed. Usually we go with tramadol or tapentadol. Okay. So now we have completed the step 1 opioids, step 1 analgesic drugs, which included the non-opioids like paracetamol and non-steroidal anti-inflammatory drugs, and also the step 2, which is opioids for mild to moderate pain, which included tramadol, tapentadol, and dextropropoxyphene and codeine. So now, what else do come in step 1? Can somebody tell me the step 1 of the WHO analgesic ladder for cancer pain management? What does the step 1 contain?
Paracetamol,
Yes.
Brufen,
Hmm.
Diclofenac, Cambriflum, Atracid.
Anybody else wants to help her? So what is step 1?
Strong opioid.
Mild pain.
What is step 1? So step 1 is non-opioid plus or minus adjuvants. So what are the non-opioids that we just now talked about? The step 1 drugs include, we said non-opioids plus or minus adjuvants. So the non-opioids include paracetamol and NSAIDs. So that is what we discussed now. Non-steroidal anti-inflammatory drugs, yes, and the paracetamol. So that is step 1. And adjuvant drugs, I said plus or minus adjuvants. And the step 2 is opioids for mild to moderate pain or weak opioids, which was tramadol, tapentadol, and with step 2 includes plus step 1, that is non-opioids plus or minus adjuvants. So what is this adjuvants? What are adjuvants? Any idea what adjuvants are? We have been talking in our ladder, plus or minus adjuvants in step 1, plus or minus non-opioids, plus or minus adjuvants in step 2, and even in step 3, we say non-opioids plus or minus adjuvants. So what are adjuvants? So these adjuvants are drugs that their primary function is not to produce analgesia, but in a particular context, they cause analgesia. So their primary action is not to produce pain relief, but in certain situations, they produce pain relief. These are called adjuvant analgesics. Can you give me an example of an adjuvant analgesic? The primary purpose of the drug is not to produce analgesia, but it can produce pain relief in some situations. So what would you give in a patient with pain due to severe abdominal colic? What are the drugs usually given to a patient with severe abdominal colic? Yes, Buscopan, cyclopam. Very good. So, cyclopam or dicyclomine, what does they do? And Buscopan is hyoscine butyl bromide. So these are muscle relaxants which produce pain relief, but their primary action is not to produce pain relief. So such drugs are called adjuvant drugs. So this dicyclomine, hyoscine butyl bromide are all adjuvant drugs whose primary action is not to produce pain relief, but in severe abdominal colic, they can produce, though they are muscle relaxants, they can produce pain relief. So what are other adjuvant drugs? Tricyclic antidepressants, anticonvulsants, NMDA blockers like ketamine, methadone, alpha-2 adrenergic agonist, corticosteroids, muscle relaxants, benzodiazepines, osteoclast inhibitors. These are all drugs which can be used as adjuvants to produce pain relief. So we have another patient scenario. An 84-year-old man who had diagnosed 10 years back with the carcinoma of prostate has had now recurrence with pain in the penis, scoring 10 on 10, which lasts for 10 minutes many times in an hour for the last 6 months. She could not even have one good night's sleep in the last 6 months and has often thought of suicide. So far, we have tried all the NSAIDs, but no response. Tramadol has been given. The patient has no relief, but he feels very tired. Flavoxate has been given, no response. Corticosteroids has been tried, but no response. Intravesical local anesthetics have been given, no response. Morphine was also tried. Little response, but the patient felt very tired. What can we do? So the opioids are also not helping him. Why do you think is the patient not having adequate pain relief?
Injection given 4-to-win Finargan.
Why do you think Fortwin Finargan can help?
Pain relief with sedative.
What is Fortwin? Can somebody tell me what is Fortwin?
narcotic drugs.
Sunil sir, are you there?
Yes, I am here.
Sir. Sir, fourth one is pendoxazine.
It is pendazosin.
Okay. So we are already seen that the opioids are not helping in this patient. We have tried with morphine, but still it's not helping. So what we can do next is we'll have to do a detailed evaluation and detailed history taking with the evaluation of his pain and understand what is the cause of his pain. So he has got pain in his pelvis, and on detailed evaluation, it was found that this was due to the bladder spasm, and the pain was referred to the penis. So his pain was basically due to the bladder spasm, and the pain was referred to the penis. Now, what step of the ladder does he need? Which medication do you think would help him in this situation? Anybody? Yes, exactly. Thank you, Manjula, for that answer. Relaxants, bladder muscle relaxants. So he was given, bladder muscle relaxant was also tried on him. That was flavoxate, which didn't give him adequate pain relief. So he was started on oxybutynin, which is an anticholinergic drug, 5 milligram thrice daily, and he had complete pain relief. So such drugs which does not primarily produce pain relief, but in certain contexts, they produce pain relief. These are adjuvant drugs. Now we have another patient with throbbing pain in the cheek and shooting pain to the left ear. What kind of pain do you think is this? Any guesses? You have learned about introduction to pain is already been taken. Sorry?
Nerve involvement.
Nerve involvement. Yes, very good. So, that is a neuropathic pain. It is a pain that arises as a direct consequence of a lesion or a disease affecting the somatosensory system. Yes, it is a radiating pain. So, usually the neuropathic pain, it radiates along the distribution of the nerve. And what is the ladder for neuropathic pain management? So the first step is tricyclic antidepressants or anti-epileptic drugs. And if there is no adequate pain relief, even after optimizing the dose of TCAs or anti-epileptic drugs, then we go to step 2. Step 2 is tricyclic antidepressants and adding anti-epileptic drugs. So tricyclic antidepressants plus anti-epileptic drugs is step 2. And if there is no adequate pain relief with step 2, then we go to step 3, which includes NMDA antagonistic drugs like ketamine, methadone, etc. And if there is no pain relief with step 3, then we go to step 4, which includes spinal analgesia. And throughout this ladder, in any step where needed, corticosteroids can be added. So the neuropathic pain ladder is step 1 is tricyclic antidepressants or anti-epileptic drugs. Step 2 is tricyclic antidepressants and anti-epileptic drugs. And step 3 is NMDA antagonist. And step 4 would be spinal analgesia. And throughout these steps, in the ladder, we can add steroids wherever necessary. So this is a 2009 systematic review about the effectiveness, a comparative study between the effectiveness of gabapentin and or tricyclines for diabetic neuropathy and post-herpetic neuralgia. So it was found that the pain relief achieved, there is no much difference in the pain relief achieved with gabapentin as well as tricyclic antidepressants for diabetic neuropathy and post-herpetic neuralgia. The only difference is that gabapentin is a very expensive medication, whereas tricyclics are cheaper medications. So what are tricyclic antidepressants? Amitriptyline, imipramine, and nortriptyline are the common TCAs. And the common side effects is somnolence, mental clouding, and the anticholinergic side effects include dry mouth, blurred vision, constipation, acute angle closure glaucoma, tachycardia, and urinary retention. And usually this medication, the amitriptyline, is given in a dose of 10, it is started at 10 milligram or 25 milligram. In the evening hours, usually we prescribe at 7 p.m. at night. This is because one of the most common side effects of amitriptyline is the early morning drowsiness. So to avoid this early morning sedation, we ask the patient to take the drug at 7 p.m. at night. And then if the patient is having poor pain relief and no side effects, then we titrate the dose by 10 or 25 milligram every 5 to 7 days. And usual dose range is between 25 to 100 milligram. And the analgesic effect onset is within 1 to 2 weeks and peaks around 4 to 6 weeks. The anticonvulsant drugs, the mechanism of action is that suppression of the paroxysmal discharges and their spread from the site of origin and reduction of the neuronal hyperexcitability. The indication for anti-epileptic drugs is the lancinating or periodic, like episodic paroxysmal neuropathic pain. So usually they say exaggerative pain or severe excruciating pain that comes and goes off, such kind of pain, shooting type of pain. Those pains, the first line of drug would be anti-epileptic drugs. So carbamazepine is usually used as a first line drug for trigeminal neuralgia. It is metabolized in the liver and is eliminated by the kidney. It is 70 to 80% protein bound and it induces its own metabolism within first month of the treatment. And that is known as auto-induction. And once the auto-induction is over, completed, the half-life in chronic therapy is 10 to 20 hours. The side effects with carbamazepine are drowsiness, diplopia, headache, ataxia, nausea, vomiting, dizziness. And these side effects usually set in within a week of the initiation of therapy. And the rarer side effects include Stevens-Johnson syndrome, photosensitivity, exfoliative dermatitis, erythema multiforme, aplastic anemia, toxic hepatitis, and pancreatitis. And about 1 in 30,000 people who take carbamazepine will develop serious blood disorders. Usually the starting dose is 100 to 200 milligram once daily or twice daily. And in every 2 weeks, it can be increased in an increment of 100 to 200 milligram. And the maximum dose would be 800 to 1200 milligram. Next is about the valproic acid. Valproic acid is quickly absorbed and is taken by mouth. And without food, the peak levels in the blood is reached in approximately 2 hours. It is highly bound to proteins in the blood and 95% it is metabolized in the liver and its half-life ranges from 8 to 16 hours. The most common side effects include tiredness, dizziness, nausea, vomiting, tremor, hair loss, and weight gain. And the most feared is the liver damage. And usually this occurs within first 6 months of the initiation of therapy. And the usual recommended dose is 200 to 500 milligram at night, which can be gradually increased up to 1 gram daily. Next, regarding other anticonvulsants, gabapentin and pregabalin, the advantages are it has proven analgesic effect in neuropathy with good tolerability and less chances of drug-drug interactions. And the side effects include somnolence, dizziness, ataxia, fatigue, impaired concentration, edema, and weight gain. And gabapentin, it has to be slowly titrated in multiple steps to reach the effective dose and is less expensive compared to pregabalin, which is more expensive, and the titration can be attained in 2 to 3 steps to the effective dose. Now, we have different recommendations for the pharmacological management of neuropathic pain. So we have recommendations from the European Federation of Neurological Society. We have the NICE, the National Institute for Health and Care Excellence recommendations. We have the recommendations from Canadian Pain Society and also Special Interest Group on Neuropathic Pain recommendations. So for the regarding the recommendations, the pharmacological management of neuropathic pain, we have different recommendations. And according to the NICE recommendations, amitriptyline, the first line therapy, the first line drugs for all neuropathic pain includes amitriptyline, duloxetine, gabapentin, pregabalin, and capsaicin. And the second line would be one of the remaining 3 oral drugs of the first line therapy. And the third line would be one of the remaining 3 oral drugs of the first line therapy. So this is the NICE guidelines. Now, we have already seen in our ladder for neuropathic pain management that corticosteroids can be included in any step of the ladder. So corticosteroids, they can be used as a multi-purpose analgesic. Can be used for neuropathic pain, bone pain, headache from raised intracranial pressure. So the corticosteroids, they reduce the peritumoral edema there. It can be used in arthralgias, pain from obstruction of hollow viscus or organ capsule distension, for pain from spinal metastasis. And the other beneficial effects of corticosteroids include it improves the loss of appetite, malaise, and nausea, and also the quality of life of the patient. So the mode of action is it decreases the edema, it has an anti-inflammatory effect, and it can also be used as a mood elevator. The long-term side effects of corticosteroids include myopathy, adrenal insufficiency, and immunocompromise. And the commonly prescribed steroids is dexamethasone. The advantages are it has a long duration of action with a half-life of 36 to 54 hours, and it has less mineralocorticoid effects. So, and also once a day, dosing is usually preferred. The other steroids include prednisolone and methylprednisolone. So the corticosteroids, the dexamethasone is usually given in a dose of 4 to 8 milligram once daily per orally for 5 to 7 days trial. Steroids can cause insomnia. So always ensure that it is given in the morning. So always prescribe steroids in the morning. For long-term therapy, the lowest effective dose is preferred, and always make sure that a gastroprotective agent like proton pump inhibitors should be concurrently prescribed with corticosteroids. We have other adjuvant drugs also, which includes skeletal muscle relaxants, thiocolchicosides, tizanidines, fluoxazone, neuroleptics, olanzapine, antibiotics, sedatives, anxiolytics, laxatives, etc. So all these are drugs. So basically what you need to understand is that adjuvant analgesics these are drugs which are primarily the drug does not produce pain relief, but these drugs in particular context or situations, they can produce pain relief. And this drugs can be prescribed along in all the steps, in step 1, step 2, or step 3, whenever you feel that there is a need, this adjuvant drugs can be prescribed. Thank you.
Thank you all. Thank you all for listening. Unfortunately, we don't have a case presentation for today's session. If you are having any queries regarding this topic, you can ask Dr. Amirtha. You can put your queries in the chat box or either you can unmute from your end and talk. Any doubts or questions? Ma'am, I think they have understood everything. No
Does
questions.
this mean that my class was very clear or you have not understood anything? So basically what you need to understand is that what we were discussing today was the step 1 and step 2 of the WHO analgesic ladder. And the step 1 of the WHO analgesic ladder is for mild pain, which includes non-opioids plus or minus adjuvants. And when we say non-opioids, it includes paracetamol and NSAIDs. And NSAIDs, we were talking about NSAIDs, the non-steroidal anti-inflammatory drugs, they act by inhibiting the COX enzyme, cyclooxygenase enzyme. And this cyclooxygenase enzyme, I didn't see that Manjula's question. Okay, so this cyclooxygenase enzyme exists in two forms, that is COX-1 and COX-2. And this COX-1 is a normal, it's a constitutive enzyme that is present in normal tissues. And it is responsible for the protection of the stomach, the kidneys. So, and it is essential. So COX-1 enzyme is essential for the body. Whereas COX-2 enzyme is something which usually is being produced during an inflammation. And it will inhibit this COX-2 is causing vasodilatation, and also it inhibits the platelet aggregation. So COX-2, we need to inhibit the COX-2, and the inhibition of COX-2 is a desirable effect. And NSAIDs are basically classified based on the action on COX-1 or COX-2. And they are classified as non-selective COX inhibitors, which inhibits both COX-1 and COX-2, preferential COX-2 inhibitors, which have more action on COX-2 than COX-1, and selective COX-2 inhibitors. Selective COX-2 inhibitors means they inhibit only COX-2 enzyme. So when this COX-1, it's non-selective COX inhibitors, when they are used, the risk is that we have gastrointestinal side effects, as well as they can affect the kidneys, and also they can cause myocardial infarction as well as stroke. So that is when a COX-1 inhibition occurs. And the selective COX-2 inhibition, if it is selective COX-2 inhibition, that means that the COX-1 is preserved. So the gastroprotection action is preserved, but their long-term use can result in prothrombotic effects. So it can produce myocardial infarction as well as stroke. So initially it was thought that selective COX-2 inhibitors like celecoxib, etoricoxib, and diclofenac are all more preferred than non-selective, but for cardiac patients, it should be used cautiously. And the safest NSAID with least risk is ibuprofen. I hope it's clear. So fentanyl is a step 3 opioid. So we were talking today about step 1 and step 2. So step 2 is opioids for mild to moderate pain. And that includes weaker opioids like tramadol, tapentadol, dextropropoxyphene, codeine, etc. But fentanyl, morphine, methadone, all these are step 3 strong opioids, which are step 3 opioids. I think you'll have class on opioids. So we'll be continuing the next week with the session on opioid. So we'll be talking in detail about the opioids in that session. I think things will be more clearer then. But it's important to understand the ladder, the WHO analgesic ladder, and the medications or the analgesics being used at each step. And that is important so that you understand when to escalate to the next step and what in next step. So usually with patients with mild pain, we go with step 1, which is non-opioids, which include paracetamol or NSAIDs, plus or minus adjuvants. And for patients with more pain, then we go to step 2 for opioids for mild to moderate pain, like tramadol, tapentadol, etc. And with the step 1, non-opioids plus or minus adjuvants, and severe pain. Patients with severe pain, we go to step 3, that is stronger opioids like morphine, fentanyl, methadone, along with step 1, that is non-opioids plus or minus adjuvants. So always keep in mind that adjuvants are drugs which are not primarily action of the drugs is not pain relief, but their action can produce pain relief in particular context. And these include drugs like tricyclic antidepressants, anticonvulsants. Then we have NMDA receptor antagonists like ketamine, methadone, and also the neuropathic step ladder. We go for step 4 would be spinal analgesia, and corticosteroids have a major role in as an adjuvant analgesic. And one more thing to keep in mind is that suppose a patient with a moderate pain is having, but is an epileptic patient on an anti-epileptic drug prone to develop seizures, always keep in mind that tramadol should not be prescribed. Tramadol reduces the seizure threshold, as well as tapentadol will reduce the seizure threshold. So it is not a preferred drug in patients with patients either on anti-epileptics or those are prone to develop seizures. So there we can go with low dose of more stronger opioids like morphine. Yes. Anybody wants to ask anything? I think there are no more questions.
If there are no more questions, we can wind up today's session. Thank you so much, Amirtha ma'am, for that elaborated session. Thank you all for joining for today's session. We'll be having the next session on Friday. The topic will be on opioids. So we'll see you on the next session. Bye-bye.